First of all, welcome to all of you who are joining us for the Hemlock Society of San Diego's bi-monthly program on end-of-life issues. Today, we're focusing on hospice and end-of-life choices. And to discuss these issues, we invited three wonderful guests. First of all, we have Dr. Flora Danke from Preva. She's Associate Medical Director at Preva Hospice. She's got a long experience in family medicine, and she's well involved in skilled nursing homes, I think, and physician for skilled nursing homes. She's I saw where she did some advanced study in geriatrics, but she's got a wealth of knowledge that she can contribute to our discussion here. And then there is a second guest, there's Jamie Hunt from Top Care Hospice. Jamie was an RN nurse in the intensive care unit for many years. And so obviously in that position, she came into direct contact with end-of-life issues and the kinds of problems surrounding decisions that the patients have to make and family have to make. And so we're delighted to have her as well. And then finally, Dr. Trevor Raby from Accent Care. Dr. Raby is the medical director there, and he has been in his career, long career, internist, pulmonologist, critical care respiratory specialist, and he is somebody who also has a lot to contribute to our discussion. Obviously, certainly in some of those positions, he's come into a lot of immediate situations where end-of-life issues are front and center. The program format today, for those of you who are new and haven't joined us before, is pretty straightforward. Each of our guests gets 10 to 15 minutes to present, and then there's a 5-minute Q&A session afterwards directed to them. Without any further ado, I guess I'm going to turn the program over to Dr. Flora Danke. Dr. Danke, it's your turn.
Thank you, Barry. Thank you for the invite, and I appreciate the format, and I appreciate you allowing me to go early. So I know that your audience is very educated about medical aid in dying, so I'm trying to share things that you might not know. And so I call them the pearls of medical aid in dying. And one of the pearls is that taking medical aid in dying meds doesn't go on your death certificate. As you know, it's the law. So what goes on your death certificate is basically your hospice diagnosis or the palliative diagnosis that is the cause of your death. So that's one thing I wanted you guys to know. One other great pearl is that I found out that if you pass away in your home and you own your home and you have to sell the home within 3 years of your death has to be reported to the new buyers. So I don't know how many people know about this. One of my patients actually sold her home and asked the new owners if she could rent back for 6 months. And once the transaction took place, then she felt comfortable and she took the MAID meds and passed away. If you receive Social Security benefits, retirement benefits, or annuities, think about when that's deposited into your account every month, and then plan to take medical aid in dying meds after that. I didn't realize that was an issue until patients are trying to tell me, I'm just trying to get past the first week of the month. So something to think about. I also feel that taking medical aid in dying is not a spectator sport. And so I want the patient who is doing this to feel in absolute control of who is going to be present when they take MAID. Now, some people, they will have the nurse saying, I have to be there. Nobody has to be there. I like being there. My name's on the prescription. I want to be there to assist the patient in taking the meds, how to take the meds, how to reminding them that, I'm going to give you sorbet and I'm going to do things like that. So it's just helpful to be present and to make sure that everything goes smoothly. You do want to be working with a hospice that is supportive of MAID, medical aid in dying. So I'm going to use MAID as the mnemonic instead of constantly saying medical aid in dying. But you definitely want to work with a hospice that supports it. how do you know if a hospice supports it? Go to their website. And actually, I'm going to have a handout that I already forwarded to Pat and Pat Fisher. And it's going to have all the pearls that I'm talking to you about right now. But also it has the link to the website with a Priva that has me talking about medical aid and dying. And that's how you can tell if a hospice supports it. Also, it's key because a patient's family member contacted me, wanted assistance with medical aid and dying for her brother. So then I called the hospice company and I said, hey, this patient is no longer able to swallow. He wants to convert to a Foley catheter for rectal administration of MAID. And the nurse manager said, stop right there. We don't support medical aid and dying. I give me the paperwork. Wait, who did you speak to? I mean, just threw a big fit. And I just said, your patient, could you please help me with an enema so that he can take the MAID meds in the morning? Again, pushback. So I left my house at 10:30 at night to go and give the patient an enema because it just wasn't worth fighting with the hospice company. I've also had called the hospice company to come and do the death visit, and they refused because the nurse refused. And I said, it's just like any other death visit. And they said, nope, I'm religious and I don't support it. So those are problems that we don't want to see at the end, so that's why you want to go with a hospice that supports medical aid and dying. And then let's see. You really want to, I don't know if I said this already, but I had one patient who decided that he wanted 35 of his family members to be present when he takes medical aid and dying, and he ordered 20 pizzas and a keg. So some people have a party atmosphere, and he's like, celebrate my life, don't mourn my death. But then I have other people that just want me, and that's okay too. So, but you get to decide who's going to be there. The oldest patient that took MAID with me was 102 years old. And the youngest patient was 20 years old. So if you fall between those two age groups, you're probably good. Okay. But the 102-year-old was pretty funny. He was actually a psychiatrist. And he's like, if I don't do this, I'm never going to die. But I'm like, you're already on hospice. So I know you're going to die. We just don't know when. And he goes, well, don't be surprised if I'm one of your failures. But he ended up passing away with MAID. One size doesn't fit all. So I have a former NBA player who was 6'8" and he's 290 pounds. And a woman who's 5'1" and 100 pounds isn't gonna need as much medication as the 6'8", 290 pounder. So I talked to Dr. Lonnie Shavelson, and he's the medical director of the National Clinicians for Medical Aid and Dying. And he said that I got permission so I can actually increase certain meds in MAID to make it more appropriate for larger people. You probably know this, just because you ask for MAID doesn't mean that you have to take it. And just to know that the MAID medication, I only add 2 ounces of apple juice. I don't use water because I heard water causes the amitriptyline to cause more burning. So I add apple juice to kind of try to sweeten it up. It doesn't help a lot. It's very, very bitter. But that's when the sorbet comes in play. And that's why before you drink the medical aid and dying meds, I'm going to give you a couple of scoops of raspberry sorbet. Then you drink the cocktail, and then I give you more scoops of the raspberry sorbet. Some people like to know this. The Valium causes the sleepiness. The morphine causes respiratory depression. The amitriptyline, the phenobarbital, and the digoxin are cardiac toxic at high doses. So that's dosed to stop the heart. Once you drink the made cocktail, from minute 0 to minute 8, you're going to fall asleep. On average, my patients fall asleep within 3 to 5 minutes. From minute 8 to minute 20, you will lapse into a coma. You can still hear us, you just can't respond. Let's see. On average, dying from after taking medical aid and dying, it takes on average about 1 to 2 hours. And I know people are kind of surprised at that, because they think once they drink it, they're going to die right away. And some people it does. I had a patient pass away as quickly as in 10 minutes. And I've had another patient who took it rectally. Rectal is not absorbed as well. And so she passed away in 13 hours. And I did not leave her side. I stayed with her until she passed away. I'm just marking off things that I'm telling you guys. Oh, and the national average, the longest person that it took to pass away, he took 26 hours, and he was a rather large man, and he was young. So things that will factor into prolonging your death with medical aid and dying is like GI cancers, because your absorption isn't as great. A history of high narcotics and Xanax use, having severe constipation, having a history of IV drug use, and having being an age of less than 55, and also having a history of alcohol abuse, or that just increases your risk of not dying right away. You will die, you just won't die right away. This is interesting. Once patients sign the made request form, and your witnesses sign with you on that made request form, it is good for your lifetime. Now, you can't sign it until you're actually appropriate. Okay, you have to have a terminal illness. So you get, now that you're, right now, that if you're healthy and feeling great, you can't go, oh, I'm going to go get my 2 witnesses and sign away. You have to be appropriate. Okay, but once you sign on, it's good for your lifetime. And a lot of patients don't know that. The made meds, that's another thing. Once the made meds are dispensed from the pharmacy, they have an expiration date of 6 months. Okay. Apriva Hospice does support voluntary stopping eating and drinking. Usually to get onto hospice for that, you have to have documentation. So let's say your doctor says that, okay, you weighed in at this weight and there's a 15-pound weight loss, then you're good to go coming onto hospice, and you're voluntarily stopping eating and drinking. Okay. Medicare is requiring medical records, so we can't just take your word for it. We have to have actual proof from your doctor that you're losing weight. As far as palliative sedation, usually the way we get the palliative sedation patients are, like, let's say they're hospitalized at a hospital, and the palliative team calls up and says, hey, we have a patient that wants to go home on palliative sedation. We actually then coordinate with the pharmacy, pick up the what we call sapphire pumps, and we have it ready for you by the time you get home, with your hospital bed and everything. So it is possible. We do it. We've done it many times. But let's say that you're at home and you're suffering and nothing is easing your pain. You have pancreatic cancer and you're just going downhill, but nothing is controlling your pain. That's when we would bring in the palliative sedation. Also, what we do is we do extubations at home too. So I will accompany the patient from the hospital. If they've been intubated at the hospital, they're put on a ventilator, transported home via ambulance. I will meet you at your home. And again, having all the pumps and the hospital bed ready for you so that we can take you off the ventilator and manage you that way. Let's see. I know there's some doctors out there that they don't mandate that you're on hospice, but the reason why I have patients go on hospice is because it decreases my liability and my malpractice. Hospice vets out the appropriate patients. And so you have to have a terminal diagnosis to participate in hospice and medical aid in dying. That's my feeling. The law says that you don't, but I feel safer and it'll protect my medical license if you are with a terminal illness and you're vetted out by hospice. But if you're not on hospice, I'll talk to you regardless if you're on hospice or not on hospice. But as far as participating in medical aid and dying, I would like to decrease my liability and have you on hospice. By the way, if you die at home and you're not on hospice, you become a medical examiner's case. When I call the mortuary and I said, hey, Mr. So-and-so just died, they'll say, is the patient on hospice? And I can say yes. If not, they have to refer the case to the medical examiner's office. Let's see what else. If you're having problems swallowing, or if you have severe nausea and vomiting, a Foley catheter can be placed in your rectum to deliver the medical aid and dying meds. You still have to have the strength to push down on the plunger. It usually takes the weight of your hand, though. It doesn't take much strength to push down the plunger that holds the medical aid and dying meds, but you need to be able to administrate it to yourself. Let's see what else. Once you pass away, I call the mortuary, I give the causes of your death, and I sign your death attestation. I'll communicate with your loved ones. If you have loved ones, that I had completed your death attestation. And once that step's completed, it usually takes anywhere from 10 to 14 business days for the mortuary to have your death certificate ready for purchase. And that's about all my questions. If you have any questions, I'm willing to take any.
I guess the big question that's been brought up by two people so far, and I'll just read the long one, is there any possibility of being able to sign up for MAID while in good health for future dementia? There's a great deal of dementia in my family line. By the time my physical health is at a level for MAID, my mental acuity probably won't be sufficient for it to be accepted.
So what I'm told is that euthanasia is law in the Netherlands and also Canada. So actually you can Google it, that they allow euthanasia, and that if you put it in your will, so with you having capacity, if you put it in your will and then you go fly over there with your loved ones.
No. The only country that will let you fly there, and if you're not a resident or a citizen of that country, is Switzerland. You have to be Canadian to be.
I'm sorry, Switzerland is my way, Netherlands. So yeah, no, I totally agree with you, Christine. I totally agree with you. But you get what I'm trying to say, right? That you can do it, but you have to go to a certain area.
Only to Switzerland.
Yeah, but you can do it.
You can't be seriously demented. You have to be still have capacity.
You still have to have capacity.
Okay.
Question.
Yes,
My husband and I are full body donation
Oh yeah.
Participants. Now, how would that affect calling the medical examiner's office? Would there be time? I mean, would our bodies still be of some value?
Yes. Actually, thank you, Nancy, for donating your body to a body donation service. That's wonderful. And bottom line is that you can still go over from the medical examiner's office. You can go over, but if your physician knows that you want to do body donation, just make sure that they're aware of it. And then your physician, if they're able to or willing to say that no, her death was expected. If your husband calls in or your family members calls into your primary care doctor and says, hey, mom's not doing really well, just wanted to let you know that she's really declining. He may order hospice, or as long as he or she is aware that you are declining, then they can vouch, because there's got to be a doctor that says, no, this death was expected. Okay, to avoid the medical examiner's office.
I would love to ask a question about the impact on life insurance. Because the choice of how you tie things up, does it have some impact on what it pays out and what doesn't pay out?
So because it's the law, Anne, there is no impact. And that's why taking MAID doesn't go on to your death certificate either. So unless you tell somebody, nobody else knows.
There's a question here about, are you comfortable with the use of magic mushrooms to ease the way for everyone involved, particularly the patient?
Well, magic mushrooms isn't legal in San Diego. So it's not decriminalized like marijuana is. And so basically, I don't really have experience with that. People in Oakland, California, where magic mushrooms are decriminalized, they have a lot more experience. So I can't really even talk about it. I just know that you have to keep eating it, to stay in that state. But that's a hard question to answer. It's a good question, a hard question to answer, because I don't have experience.
So Sharon has her hand up. She also, I think it's the same question. The meds expire in 6 months. Why can't it be longer? And why does alcohol abuse interfere with the length of time to die?
Great question. Hi, Sharon. Okay, let's see. It's the expiration date is made by the pharmacy, and they're the ones. But I had a patient whose meds were 9 months old and it worked just fine.
Right.
And so, how many of us have taken a 2-year-old Tylenol? Totally different, kind of meds, but these are supposedly expired in 6 months, but I've seen it work. I have another patient who is coming up to about a year, and he finally asked me if he could take his medical aid and dying meds. And I asked him, do you want to pay for another set of meds? And he's like, absolutely not, because they cost about $700.
Why can't that get changed?
Because it costs the pharmacy. So alcohol abuse usually interrupts or it affects the liver and causes cirrhosis. And the liver and our kidneys are our filters of our body. And so when the meds go into our body, it's metabolized through the kidney and our liver. And that's how it doesn't get broken down. So you stay in a state of a coma, so you don't die right away. Does that make sense?
Sure.
Thank you. That's great.
Thank you so much, Dr. Danke. I know I know you're sort of probably looking at the clock there someplace. Thanks so much for the wonderful information and taking time to answer questions for us. And I'm sure that some people will have some questions for you as they think about what's covered today. So again, thanks so much for joining us. And I guess we'll then move on in the program to Jamie Hunt. Again, Jamie is from Top Care, and Jamie, the floor is yours.
All right, thank you. Just gonna pull something up here too. I have a little bit of notes. I really appreciate you having me on. Like Barry said, my name's Jamie Hunt. I'm the owner of Top Care Hospice. And I just want to tell you a little bit about myself and why I started Top Care. As Barry had said, I am a registered nurse, and I worked in the ICU for 10 years, cardiac ICU. And during my time there, I saw a lot of really great stuff. And honestly, I loved my job there. But there were a lot of times, a lot of ethical dilemmas, a lot of things where, the 90-year-old or 95-year-old is in the ICU and I'm just distraught. I'm like, what are we doing here? I wanted to be a nurse because I want to help people. And this just doesn't seem like I'm helping this person. And you know, a lot of times in the ICU, you are in that mind of like, we've got to save them no matter what. And then, you know, it'd come down to maybe 24 hours or a couple of hours beforehand. And then we'd have to say, you know, there's nothing else we can do. And this created a very traumatic experience for the families and the loved ones. And so I kept thinking there's got to be a better way. You know, we have to educate our community. We got to prepare people for death so that it's not so traumatic. And so death is always sad, but maybe we can take the trauma out of it. And so that's why I got really interested in hospice. And I grew up in a family business, so I always knew I wanted to run a business someday. And so got really interested in hospice and started Top Care in January of 2021. So we're fairly new. And what else was I going to say? I'm sorry, I'm trying to lose my thoughts here. But basically, I created Top Care because I want to educate and empower people to make their own decisions based on the information that's available. Because sometimes in the hospital, we're so focused on care that we're like, okay, you can do this surgery or you can go home and die. And we kind of present it like that. And it's not the reality of it, right? You could say, oh, you could do this surgery and there's this risk factor and this risk factor, or you could go home, you could be with your family, you could enjoy the rest of your life there and die at home comfortably. And so that's why I started Top Care. And I'm just going to read to you regarding the medical aid in dying, kind of, you know, we presented on our page. We have our whole spiel on there, but so our mission, we provide empowering education and exceptional personalized care for our patients, families, and community in order to enhance comfort, dignity, and choice through the end of life. And I came up with this mission hours and days. This was even before I knew End of Life Option Act. And so when we had our first patient who wanted to use End of Life Option Act, I was kind of like, sure, why not? Like, why wouldn't we do this? Like, it's legal. You know, it doesn't really matter if I agree or if I disagree. That's not my role as a healthcare provider. My role as a healthcare provider is to educate, empower, and provide choice. And so whenever, like, that's kind of our stance on it. We do not deny care to anyone. And it's not like because we're Medicare funded, we can't technically as a hospice say, we do End of Life Option Act or we do medical aid in dying, because we can't. But we do hospice. And if somebody wants to use End of Life Option Act, we will support them. So that is our stance. And then the way, if somebody chooses to, they come to us and they want to use End of Life Option Act, we have some providers that we work with, but again, we educate them, we encourage them to do their own research, we can help them if they have questions, and at the end of the day, they make their own decisions on that. What else about us? Another thing about us is that we offer a holistic approach to care. I know that that's kind of like all hospices have this holistic approach to care, but we also offer like sound healing, aromatherapy, Reiki, music, all these different things so that we can create a more comfortable death, a less traumatized death, and show the family members, hey, guess what? This is death, and it doesn't always have to be traumatizing. It can be beautiful. And so we've created this program. It's called the Threshold Program. And it's a group of people that go out the last 5 to 10 days of death, whether they're using, you know, the medical aid in dying or if it's the natural death. And we offer these modalities to patients and families. And it's been a beautiful experience. And we've had some really great feedback from that. So just wanted to let you guys know about that a little bit. And I'm trying to think of anything else I wanted to say in my spiel, but I think that's it. So I'll just open it up for questions now.
The first one, Jamie, is where is Top Care located?
Our office is located in Kearney Mesa, and we service San Diego County. So we have patients as far north as Vista, I would say, and then East Alpine, South Chula Vista. So basically the whole county.
The next question is threshold extra charges?
No, that is included.
When you,
well,
yeah,
go
I'm not clear about that. You say you find somebody to help out to do the End of Life Option Act. That's not included in your Medicare expenses, is it?
No, it is not. It is not included. But
So-
I know it's included in Kaiser's insurance. So if you have Kaiser insurance, it would be included, but Medicare does not pay for the medications or doesn't support End of Life Option Act because it's federal.
Right. So how much extra expense might there be for a patient who's using your hospice to get medical aid in dying?
It depends on the provider they choose and how they go about it in their own way. Like I said, our medical director will prescribe it if that's what they'd like, but we let the patients do their own research and choose their own provider. And then it's separate from our hospice. But like I said, we support them, but we're not doing it through our hospice.
So they're terminally ill and they may not know. Do you give them choices and tell them what may follow after that? As far,
Like if somebody says, oh, sorry, go ahead.
as far as expense goes, for example.
Yeah, we usually we can tell them how much the medications are and how much physicians charge in the area. We can give them like the ballpark figure. But like I said, we don't do it internally. It's an external service.
Can your hospice people be present during ingestion?
We have had people present during ingestion, yes. Myself included.
Where is the threshold program available geographically, and who is the contact person if I wanted to invite someone to write a blog post on it?
Okay, yeah. It actually was created by my employees. Rebecca Finn, she's our bereavement counselor. She kind of headed it up. And so she would be the contact, and her, I can text the email to you in the chat here, but she would be the best person to contact. And so it's her, our spiritual counselor, RN, and certified home health aide. The four of them created this program. And so they're the ones that are kind of heading that out. It's really, really beautiful.
What is the cost of your hospice arrangement?
So hospice is a Medicare benefit that most people who worked in the United States paid into. And so once you go onto hospice, there is no outside cost to you that is related to your diagnosis. So let's say you are admitted for heart failure or heart diagnosis. So your heart medications would be covered, as well as any comfort medication. So morphine, lorazepam usually would prescribe, or anything for comfort is going to be covered by hospice. And then usually if you're on something else for, let's say, I'm trying to think of something outside, like I'm blanking right now. Like, let's say a Pepsid, like let's say you're on Pepsid. That would be covered by your other insurance that you're already using through Medicare. So usually there's no extra cost to somebody who wants to go on to hospice. So it's free basically.
There's a question here. Is there a website link where I can sign up for MAID?
It's way back.
The answer is no, except ACA MAID, the website that goes with that organization. And you can see ACA MAID, a American Clinical Academy for Medical Aid in Dying, I think is what the initials are. And they will have places where you can find a provider. You have to fill in the information about yourself, and lots of videos about the whole process, a lot of information. But I don't know that you can sign up there for MAID. I think you have to find your own providers and your own hospices.
Amy, can I ask you a question about the you mentioned that hospice is basically free, but Can you explain a little bit about the services that a patient might need that aren't covered by hospice? In other words, Medicare covers hospice directly, hospice related services, but then patients might need other kinds of things. And can you explain that a little bit so that people get a sense of what else is involved?
Yeah, okay. So one example would be, let's say, here's an example where it would be covered, and then I'll give you an example where it wouldn't. Let's say you're on for heart failure, because that's just an easy one, like the heart thing. So you're on for some cardiac disease. And then let's say you have like a benign tumor right here on your head that's causing you some pain that you want to get removed. So you're going to go to the doctor and you're going to get that removed, and that's going to be covered by Medicare, like your normal Medicare, because it's not related to your heart diagnosis, if that makes sense. So there would be no outside cost for that. But let's say you're on hospice for heart failure, and this would never happen, but I'm just using it as an example. You want to go and get an angiogram because, they go up in your vein and they look and they see your heart to make sure that you don't have any clogs in there. You want to go and get an angiogram. That would not be covered by hospice because that's part of your hospice diagnosis, and that's curative. It's not comfort. And so if somebody were to choose to do something like that, that would not be covered by hospice. Does that make sense? It probably would never happen, because why would you be on hospice if you want to go get an angiogram? But that's just for an example.
What are the kind of services, for example, might be a person in hospice need? What are the type of home health care services might they need that might not be then covered by hospice?
Oh, okay. Well, why don't I start by saying what is covered, and then I'll go into what's not. So what's covered is nursing visits. So typically a nurse will visit anytime between 1 to 3 times a week if somebody's stable, every day towards the end of life. And those visits are typically like an hour. We also provide certified home health aides that provide bathing, grooming, and those are usually like 2 to 3 times a week as well, an hour each. We have volunteers. Spiritual counselor can come in, talk to you about those questions that come up when you're dealing with things like this. Social worker, they come in and help support, help find mortuaries, help find other services, complete advanced directive if you haven't done that. And then we also have a physician on staff who can make house calls, prescribe. We have a 24/7 nursing line, and we can make visits when needed, any time of the day if necessary. We provide medical equipment, hospital bed, shower chairs, wheelchair, walker, those types of things. And then all your medications that are related to your diagnosis are also provided and delivered to you. So that's what's provided. So let's say you want care, like a caregiver, like 8 hours caregiver a day, that is not covered by hospice. Let's say you want a nurse 24/7 in your home. Unless you're in crisis, there is crisis care in hospice, so we can provide crisis care, for 24 hours, but usually you are going to have to pay that out of pocket if you want a nurse 24/7. I'm trying to think of some other things.
So hospice care is not home health care. That should be
home care. Yes. Mm-hmm.
Can I ask you a question? I thought the National Hospice motto, as it were, is that we neither prolong nor hasten death. How, if that's the case, how can you justify using the End of Life Option Act? Is that a problem?
Well, we're not doing it. So we're not using Medicare dollars to pay for or coordinate End of Life Option Act. We are supporting our patients and providing hospice care. And if they choose to take the medical aid and dying medications, that's their choice. That's their right. It's legal in California. And we're going to continue to do hospice and support that patient while they die, whatever that may look like.
It may account for why so many hospices will not help people who choose the End of Life Option Act. Yeah.
I think so. I think sometimes it can blur lines, or people might have certain beliefs that they bring into their care. And so I think, like, when we just look at that mission statement and we say, we do not deny care to anyone, and we encourage people to make their choices, it's kind of like, it doesn't matter if we agree or we disagree. We're healthcare providers and we're here to do hospice. And that's what we do.
Thank you.
I have a question. If you receive donated money, where is that money used for? And could you explain where it goes and how it's used throughout hospice?
We don't receive donated money, so we don't have a foundation. We're purely insurance fund.
Uh-oh. Lost your audio.
They muted there. All right, sorry.
There you go.
So we don't have a foundation. We don't receive donations. We receive our money from Medicare, Medi-Cal, and private insurance. And so all the money we receive, we use to run our business.
I want to say thank you. You know, I have to say, at the end of life, who doesn't want a loving team around them that's also competent? You know, it seems to me like you bring the best of the worlds together, that softness that everybody wants, and yet the competence that you know you're dealing with competent people. And so I want to thank you for your dedication, and I'm definitely going to sign up ahead of time. You know, just thank you very, very much.
Thank you, Anne.
Actually,
And
there's
one
a
thing
lot
I
of-
just
a
go
lot of
ahead.
messages on the chat, thanking you and Dr. Danke and everybody who will do this very much for their dedication and their intelligence and their choices. Go ahead. I'm sorry.
And then really quick, before I answer another question, because I forgot to say it in my spiel, we do also support voluntary stop eating and drinking. And that is a way for somebody who was talking about the dementia, like, if you write in your advance directive, do not feed me if I can't feed myself. That's a way kind of to do that in a way when you're unable to make your own decisions, I guess.
There's a question here from Sharon. Can I assume my Medicare Advantage plan will cover me the same as regular Medicare?
Yes, it will. It may prevent you from having as many options. So let's say your Medicare Advantage plan partners with a certain insurance, and that insurance doesn't work with this hospice that you want to work with. There might be some difficulty there. I feel like straight Medicare is the best, but it depends on your needs. I know, like, there's a lot out there, but usually the just basic Medicare, you have a lot more options.
And Nancy Stern has her hand up.
Yes, could you clarify for me, Jamie? I thought I heard you say when you started and you were going through your spiel that your medical director would prescribe medical aid in dying medications. Could you explain that? Because it sounds to me like you're not doing that.
Yeah, he's not advertising it, and he's like not one of the main ones in San Diego. But he will be the second one. So he definitely will sign and be the second one.
'Cause you need two,
And
right?
then, yep, because you need two. And then if the person, you know, is like, oh, I can't find anybody that I want to use, then he will do it. And again, this isn't the way that the physicians work in hospice is they're contractors. So he's not an employee of mine. He's a contractor, and like, he's separate from Top Care, although yeah, he represents us, but that's kind of his choice, his deal.
Got it.
I had the impression that, you know, I've been advised that I have to have Medicare Advantage, and yet recently I'm finding out I'm actually paying more and a higher deductible by using the Advantage than if I just had Medicare. And I realized it's probably my doctor's office that says I have to have it, but actually I'm finding the expense is far more. So it's like not a double insurance. You give up your Medicare dollars to the Advantage program, and therefore I have higher deductibles. So I'm sorry to say this, but is this your experience?
I think my experience, I'm not sure because I'm not dealing with a lot of people who are like doctoring with these programs, but I know like I said, there's certain offices that are contracted, certain hospices that are contracted, certain hospitals that are contracted with these Advantage plans. So it just might limit your choice, is what I know. I don't really know about the money.
Does your hospice work with Kaiser patients?
We do. And just to clarify, because I feel like that's a confusion for a lot of people, is like if they're on Kaiser, they feel, oh, I have to go with Kaiser Hospice. But if you are with Kaiser Insurance and you go on another hospice, your Medicare is just going to kick in, and then you can go on any hospice you want.
If I am in a care center in a CCRC, okay, and I am in hospice, okay, who does the bathing? Who takes precedence over that? Is it someone in the care center or is it hospice? And how is it determined how many times a week a patient is seen by hospice?
Yeah. So are you talking about if somebody's in like an assisted living or like a skilled nursing facility?
Yes.
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 Okay. Yeah. So yes, we do provide care in those facilities. And again, it's just based on the patient preference. So if the patient wants to be bathed 3 times a week, we will do that for them. If they want to be bathed more, we can do that. A lot of times the facility might have a preference, like, oh, I would like you here like 3 times a week, whatnot. So we do provide that. And then to answer your question about how often we visit patients, it's always individualized by the patient's needs. So, if a patient has a wound, we are probably going to be visiting that person a little bit more often than if somebody is stable and does not have any pain and does not have a lot of symptoms to manage. So we visit people. Medicare requires that you have an RN visit every 2 weeks. So that's basically the only like set thing. An RN has to visit a patient every 2 weeks. But I would say we visit patients usually 1 to 3 times a week on average. And then towards the end of life, like those last 7 days, we try to visit every day if we can predict it. It's hard to predict, but when somebody's actively dying, we visit every day.
But who determines? Is it the patient or is it the facility that the patient is in? Who determines who gives that bathing? Who bathes the patient? Who determines that? Does the facility have the right to say, no, we're going to bathe this patient, or no, we're going to let you take care of the bathing of this patient?
I think it's the patient's choice at the end of the day.
Is that just in California, or is that is that something that's in every state?
Well,
right to decide.
Yeah, in the hospice Medicare benefit, it's patient and family driven. So whatever they decide, they get to.
Okay.
Thank you. Jamie, thank you very much.
Thank you.
Our next
Appreciate it.
is Dr. Trevor Raby, and take it away, sir.
I am now unmuted. Hi. Hi. I'm with Accent Care Hospice, and a little bit about me. I started out as a pulmonary critical care doctor, and I started out in the 1980s. So I'm been at this a good while. And in the 1980s and in the 1990s, as the previous speaker alluded to, many patients were sent to the ICU basically to die. And I don't know how many of the other folks that might be on this presentation have witnessed what we do to patients in a critical care unit when they are on life support. And it is clearly about the worst way of dying that you could possibly conceive of. So I got involved with many families having end-of-life discussions, usually not with the patients, because by the time the patients are there, they have tubes in every orifice and can't really communicate. So I would be having lots of end-of-life discussions about quality of life versus quantity, and how we oftentimes make patients suffer at the end of life. And that led me to an interest in palliative care and hospice that I've been doing for some years now. Gesundheit.
Thank you.
Okay. So I've been given a few questions here. A lot of what hospice does and what MAID is all about has already been covered, so I'm going to try not to duplicate that. So one of the questions is to kind of differentiate between home health and what is hospice. So home health is care delivered at home, obviously, with a curative intent. The patient is ill, oftentimes recently discharged from the hospital, but the intent is to get that patient back, get their health back to the previous or a better standard. And home health can consist of nursing, physical therapy, occupational therapy, speech therapy, limited custodial care, home wound care. All of those would be covered under the Medicare home health benefit. So the only criteria for home health is that the patient does have a skilled medical need. You can't just say, I want a nurse to come by and check on me, but they're not going to do much other than perhaps take my vital signs and make sure that I'm comfortable. That is not a skilled need. You would need someone that has a physical therapy need, occupational, various modalities that I already mentioned. And the other criteria is that the patient must be homebound. Now, homebound doesn't mean that you are so ill that you can't leave the home. Medicare's definition of homebound is kind of squishy, and it basically comes down to it's really hard for you to leave the home. So if it requires wheelchairs, walkers, those types of assistance, you very likely would qualify for home health. Again, emphasizing home health is directed at curative, restorative type care. Hospice, there are a bunch of criteria that we use to determine eligibility for hospice, but essentially it comes down to one criteria, that a physician in their reasonable medical judgment believes that in the normal course of events, you have 6 months to live or less. That's the only basic criteria for hospice. Now we use in each illness, we have a set of criteria that we use to guide that, but essentially it comes down to the physician's judgment. So the hospice that I work for, Accent Care, does recognize that there are some patients that kind of fall in the middle. They do have a prognosis of 6 months or less, but they still are interested in doing some form of care to improve their quality of life, such as PT, OT, etc. And the hospice, Accent Care has a program, they call it Open Access, that we can apply to and can provide limited restorative type care. Usually it'll be 1 or 2 physical therapy sessions to help the patient, to help the family with education, what they can do, what they shouldn't do, how to transfer the patient, how to get the patient to the bathroom, etc. And we do not charge extra for those services under open access. And that was one of the questions posed to me here. hospice policy regarding pain control. Pain is subjective. We don't have an objective measurement for pain, such as we can measure your oxygen level with a pulse oximeter, your blood pressure with a sphygmomanometer. If you tell us that you're still in pain and I'm giving you whatever the amount of morphine, then we will either increase it, add something, add an adjuvant therapy, or we will address it based on your subjective perception of your level of discomfort. And as already been mentioned, all comfort medications are covered by the basic hospice benefit. That's not even a consideration. And as Jamie already mentioned, if you're on for a pulmonary diagnosis, your oxygen would be covered, your nebulizer treatments would be covered. If you're on for heart failure, then your various blood pressure medications, diuretics, etc., are also covered. Do we support a client who chooses to end their life using voluntary stopping of eating or drinking? Yes, that's a patient choice. And if that's what they want, we will certainly provide them with all the appropriate palliation that would come up. What about terminal palliative sedation? Well, first, let's understand what we're talking about. Palliative sedation is providing medications to make a patient unconscious, which will accelerate their demise. And that is something that we will do, but under very limited circumstances. It's not something where a patient would say, I need to be out of this, just put me out. We would first try to palliate whatever symptom that they're having. If they're having pain, then obviously we would provide an increased level of pain medication. If that required injection pain medication, we can provide it via a pump. Nausea medications, same situation. So we would provide terminal palliative sedation essentially for failure to control troubling symptoms, which is a very unusual situation. A skilled hospice physician, and I like to think that I am somewhat skilled in this, can almost always palliate, relieve the symptoms without actually deliberately creating a state of unconsciousness. Do we support medical aid in dying? Short answer is yes, and we do it internally. When a patient that is on our hospice requests medical aid in dying, then I will be the physician that does the assessment. I will go out, meet with the patient, make sure that they are appropriate, that they're not being coerced into doing this, that they understand the whole process, they still want to proceed. I will arrange for a second opinion within our hospice organization, again at no cost. And then there's a second visit that I will usually do virtually via Zoom or FaceTime as appropriate. And then I will prescribe the medications. So at Accent Care, there is no additional cost. We absorb the professional costs. We don't cover the cost of the medication. And I understand that it is in the $600 to $700 range. We use a pharmacy that's out of town, but I think in the Bay Area, and they will ship it to the patient or family, usually by FedEx, so that the whole process can be as short as 2 or 3 days. There's a minimum of 48 hours. but in general, it'll take several days to complete the process and get the medications delivered. What happens if a patient decides that they want to check themselves out of hospice? They can do it whenever they choose. If a patient decides that I really want to change my focus, I'd like to be treated for whatever it is, their COPD or their cancer or their heart failure, and they want to go back to the hospital and get that angiogram done or get that other surgical intervention done, they are absolutely at liberty to do that, and they can, any patient can check themselves out of hospital, out of hospice. There are, and they can in fact sign up again for hospice the very next day if they are so choose. Obviously, if they still meet the criteria. What about switching hospices? I believe that there is a limitation of you can only switch hospices once per month. Maybe there are some other callers on this, some other folks on this call that can verify that, but that's, I believe, is the regulation. I believe I've covered most of the questions that have been posed. Our hospice provides all the usual services. We have a chaplain, social worker. We had music therapy up until a little while ago, but it's not currently provided. Volunteer services, etc. So I'm open to any questions.
We have one question in chat that says, is it true if one is in hospice and needs to go to the hospital, that the hospital costs are then covered by the patient?
That it really depends. If they go to the hospital for the same condition that the patient is on hospice, then we should be covering that. The hospice should cover that hospital evaluation. Now, if the patient is admitted and decides that they want more curative type treatment, which is a very common situation, then they will basically discharge themselves from hospice, be admitted to the hospital, and at the time of discharge from hospital, they can choose to go back onto hospice.
We're getting some questions. Oh wait, that was Ascend Care. Where is your hospice?
Well, the office is located in Rancho Bernardo, but we don't see patients in that office. We obviously we're a home hospice, and we provide services pretty much anywhere in the county. And I do house calls, North County, Chula Vista, El Cajon, a lot of miles.
It sounds like.
Mm-hmm.
Does anybody have any questions that want to raise their hands? Because I'm not seeing.
Sharon has a question that hasn't been fully answered. If I have an accident and am taken by ambulance to a hospital that will not participate in MAID, what must I do to get moved to a facility where I can be helped? What if I am in ICU? Can the hospital try to stop me from leaving? And we have discovered that most hospitals, at least in the San Diego area, will not allow MAID ingestion in their hospital.
So let me take it one step at a time. If you have an accident or taken to the hospital, then that's by and large not related to your hospice diagnosis. So you are going to be covered by your usual insurance or by Medicare. Can you discharge yourself? Absolutely. Every patient has the absolute right to decline any form of medical therapy whatsoever. So if you don't want to be in ICU, you will simply say, I decline to have critical care services in ICU. If you decide to leave the hospital because you, for whatever reason, you don't actually have to provide a reason, you can discharge yourself from the hospital. There's absolutely no way that you can be constrained in a hospital against your will. In terms of MAID inside a hospital, I would be very, very surprised if you can ever find a hospital that will undertake to do that. I would be astonished.
There's a response here from Dr. Donnie Moore, who's on our board and also a MAID provider, about what happens if you don't have a place to use MAID. Donnie, you want to explain that? He says there are some board and care facilities in San Diego that will allow MAID. The law only requires a private facility or residence, but that would require reaching out to ask each facility about their policies. And there are a few, maybe somebody can help me with this, a few residential hospices where you can receive MAID in residence. But I don't know which ones they are. Does anybody have that information? Donnie, are you still on?
Yeah, I am.
This is Dr. Donnie Moore.
I'm not sure exactly which hospices, Dr. Abby might have a good idea of any hospices that have in-person hospice facilities that'll allow for MAID. But yes, so there are some board and cares that are supportive, and but it's hard to know which ones. It's a matter of like finding them, reaching out, and then asking their policies specifically.
Some people do not have a place to use MAID. At one time, we were thinking of having Hemlock House, but we can't afford it. We certainly accept donations. I think it's a good idea.
I did have a question Doctor, that you said that palliative sedation advances death, which is why you don't cover it. And my understanding is that it doesn't advance death. It just means that you're sedated as you decline and as death approaches.
Death is foreseeable, but not the intention, as I understand it.
Mm-hmm.
So people die after not having food and fluids for whatever length of time the person's sedated, or from their underlying disease, or from the other medications they're taking. It's a very slippery thing, palliative sedation.
It is indeed slippery, and certainly once you're unconscious and you're no longer taking food or fluids, that hastens death. It's not the intention, but it is the result. And like I said earlier, we will support it when we are unable to palliate whatever symptoms we're managing. And that is a very unusual situation.
Justified by the principle of double effect, as I understand it, that the effect is to relieve suffering, and double effect is death, which was not foreseeable, or it is foreseeable actually, but not the intention.
Correct. That is double effect. And no doubt that plays a role in a lot of hospice care when we are very generous with opioids, and very likely that does hasten the moment of death, but that's not the intention. The intention is to relieve suffering.
I have a question about, you mentioned being admitted to the hospital and having your option to remove yourself whenever you want. But what arrangements can be made for someone who is admitted to the hospital because of an accident and is not able to communicate? Can a family member who knows the patient's wishes can their word to remove them be accepted?
That's why there is a durable power of attorney for healthcare, in which you designate your surrogate to make those decisions for you, Dr. Rabi.
And that will be sufficient?
So sorry, we were talking over each other. Apologize.
That would be sufficient, that because we certainly have our durable power of attorneys for healthcare. Will they be honored by the hospital?
You raise a very good point, and I have certainly seen in my years of experience where physicians have not honored them. In theory, they could be sued for not honoring. In theory.
Gary might want to say something about what Final Exit Network does in that respect.
Yes, Final Exit Network, one of our services is to provide training and coaching for a surrogate, healthcare surrogate, legal, that in cases where you may not have one, or the person that you have may not be either assertive enough or knowledgeable enough to do the right job for you when you're facing that circumstance when you can't speak for yourself. It's a free service. It's available via our website at finalexitnetwork.org, I think. Yes.
I was thinking that you would also intervene. A lawyer can also intervene on your behalf if your wishes are not honored. Anyway.
That is also true for our advanced directive for dementia in particular. We had a case recently where a woman's husband died. As she, as his surrogate, said he did not want to be put on a respirator. They sent her home and then immediately put him on the respirator. Then he subsequently died. So in situations like that, our legal staff, free of charge again, would come in and see if there's a basis for any legal action.
Gary is on the board of Final Exit Network. I see some hands up. Okay, Sharon.
Thank you. I just wanted to elaborate a little on my earlier question about finding oneself in the hospital. If you've had a terrible accident, you wake up in the hospital, you're in a full body cast, you can still speak for yourself, but you're attached to 6 IVs and maybe a respirator. How do you get yourself, literally, how do you get yourself from there to hospice?
Obviously, every situation is different. If you're intubated, you can't speak, unfortunately. And that's just another reason why you really do need to have a durable power of attorney for healthcare and designate a surrogate, etc. If you are able to communicate, you can decline any form of treatment that you wish. If you're in a medical condition where you can be discharged to a lower level of care, let's say to a skilled nursing facility or to a nursing home, you can then request to be admitted to a hospice. If you're in hospital, you can in fact transition to hospice care, but only if the situation warrants it. You can't just do it because this is your preferred mode of treatment. So there is inpatient hospice care to manage a critical situation, severe pain, respiratory failure, etc.
The presumption is that I'm now in so much pain that I have now decided this is the moment I want MAID. And, I have, I maybe have a medical directive, but, it's very difficult to make all those arrangements in that situation.
No, that wouldn't work.
It would not work. You won't find a hospital that will support MAID that I'm aware of.
Yes, thank you. Dr. Raby, I noted that you said you make a lot of house calls, which is very admirable. However, if the house care is not not possible, do you actually, your facility, Accent Care, do you actually have a physical location for hospice?
Short answer is no. We don't have inpatient hospice. When if a patient of ours needs a higher level of hospice care, then we will contract with a hospital to use one of their beds. But you will still be a hospice patient.
You
Thank
mentioned, I think, Dr. Raby, before maybe you misspoke, that a patient could be admitted to hospice. That there is really no hospices that provide health care at the same time. It could be that a person could get hospice care while they're in the hospital, but they wouldn't be transferred to a residential hospice that would provide health care, if I understand it correctly.
No, yeah, I think you're correct. So if you're in a hospital, let's just say with advanced heart failure, and your symptoms have become very difficult to manage, and you're now willing to forego active management of your heart failure, we can take over your care while you're in hospital, and you will be a hospice patient.
Right.
To go back to the person who was concerned about winding up in a hospital after an accident away from home. In our advance directive, we have added a clause that says that if we have an accident like that and wind up in an institution which do not want to adhere to our specific wishes of care, we demand to be transported to a different institution who will do that. I don't know if it will stand up, but this was drawn up by a lawyer.
I wanted to say that I had an experience in an unnameable hospital with my husband dying, and they wouldn't stop chemo. And in order to get my healthcare document recognized, I had to demand to see the ethics committee, and I got him released within 24 hours. So that might be something for other people to think about.
Very good idea.
Yeah, I'd like to just clarify one thing with the doctor. He refers to palliative sedation, and I want to know if that is the same as the cocktail of drugs or ending life.
Short answer is no. It's not the same.
Okay, so then Accent Care does not provide
they do.
End of life services with the medication.
No.
Is that correct?
No, that's completely incorrect.
Oh.
We will provide all medications and medical equipment, oxygen, etc., that is required to optimize the patient comfort. The only thing that will not be covered is the actual cost of the medication for medical aid in dying.
And but will you provide the prescription for that medication?
Yes.
Oh, so you will provide that at the patient's expense?
Yes.
And you will support taking that?
Yes.
Okay, thank you.
Yeah.
You might not only consider when you have, make arrangements for your healthcare proxy that they're assertive and knowledgeable and so on, but consider their heft and their height and their strength. When my father was put in, who had dementia, the hospital, they just didn't take good care of him and tied him down, and was very quickly that he got a pneumonia. And, there really wasn't much hope. So I have 3 brothers who are big. They went in and they picked him up and threw him over one of their shoulders and took him home, and he died 3 days later. So Don't forget that factor.
Not all of us have three brothers, but
Yeah. So I would like to really, on behalf of the Hemlock Society of San Diego, thank our three presenters, because this was a fabulous, wow, hour and a half that we've just spent. And I know I've learned a lot. So Jamie Hunt and Dr. Trevor Rabi, I want to say thank you. Thank you. If there's any other quick questions in chat or something, I'm sure we can provide, point people to the right directions. Pat, do you have anything you want to say quickly closing, since you helped put all of this together?
Oh, I just want to thank all of our speakers, and I'm going to address this one question here. Bruce asked, hospice care can go on if a person goes to a hospital, yet meds are not allowed in hospitals. Our understanding is that their hospitals generally will not allow MAID ingestion on their premises. I think Sharp Hospital in their posted statement said in very, very, very rare circumstances, they may consider ingestion in their hospital, but it sounds like it's an extreme exception. And they do not even allow it in their, they have three facilities, hospice facilities, that they do not allow it there either. So there you are.
And very quickly, there's questions about the handouts, and we'll have them emailed out to everybody.
And one other comment is, you should know that most hospices do not provide medical aid in dying, and the presenters that we had today are with hospices that do. So it's very important, if you're going to get hospice care, which we highly recommend, is to find out what their policy is. And the question that Diane raised about the difference between palliative sedation and medical aid in dying is an important question. They're not the same thing at all. Palliative sedation usually happens to somebody who is at the end of their rope, not particularly asking for help in dying, but the doctors find that there's no more help that can be given. And so it's up to the doctor to administer palliative sedation. Is that right, Dr. Rabi? That's what I understand.
That's an excellent summary, and to emphasize that it's a very unusual situation that we can't manage symptoms appropriately. And if you want aid in dying, you need to ask for it. So I emphasize our hospice supports it. We don't actually promote it, so you won't find it on the website. But as soon as a patient says, I'm interested in it, then we will move into action, and I will make a house call usually within a day or two. I'll arrange the second opinion. I'll follow up and do the second visit myself, and then I'll write the prescription myself. So the whole process will only take 2, 3, 4 days at the most.
Awesome. Thank you very much. And I need to, it's 3 o'clock, our time is up. So thank you, and thank you for everybody. This, as a gentle reminder, this is being recorded, and in about 2 weeks you can go to our website and rewatch it in case there's things that you forgot about because you're old like I am. So anyway, on that note,
Christy, just to very quickly add on to that, there were several questions at the end about palliative sedation, and there's a full talk on palliative sedation on the Hemlock website that people can go back and check on.
Dr. Moore gave that talk.
Okay, thank you.